Mic check 1, 2, 3. So in this video, I'm going to talk about pathology of male genital tracts. So these are the outlines of my lecture. So you can see there'll be a little bit on the learning objectives. Then I'm gonna touch a little bit on 2022 WHO classification of tumor of the urinary system and male genital tracts, which I'm concentrated more on the male genital organs. And we're gonna go into penile and also scrotum pathology, and some a little bit explanation regarding testis and epididymis pathology, and including the prostate glands pathology. So after this lecture, you'll be able to describe the gross and microscopic appearance, the spread, and the effects of tumor of male genitourinary systems. So in 2022 World Health Organization or WHO classifications, they divided the male genital tract into penis and scrotum, and also the testes and also the paratestis into two separate categories. So you can see in the penis and scrotum, they start with the benign and also precursor squamous lesions, which consists of condyloma acuminatum, which is well known as a precursor of SCC or squamous cell carcinoma. So it can be HPV associated or HPV independent. So this you need to read in details regarding this from the WHO. And next you can see there's invasive epithelial tumors of the penis and scrotum, especially invasive squamous epithelial tumor, which is a part of SCC, squamous cell carcinoma. And other epithelium, including the adenosquamous carcinoma and also extramammary Paget's disease. And other type of scrototumor which rarely seen, which is the basal cell carcinoma of the scrotums, because this basal cell is usually associated with UV exposure, and scrotum, as you know, is not a well-known place to being exposed with UV, but sometimes BCC can develop by itself even without UV stimulations, but this is will occur in a very rare conditions. In WHO 2022 also, they divided the testicular and also paratesticular part into one separate entity, and divided tumor that occur in them as number one is germ cell tumor, which consists of non-invasive germ cell neoplasia, the seminoma, the embryonal carcinoma, yolk sac tumor, choriocarcinoma, placental site trophoblastic tumor. So bear in mind, even though this is in the testis, you still can see the placental site trophoblastic tumor, the epithelioid trophoblastic tumor, cystic teratoma, mixed germ cell tumor, and this is the most common, the mixed germ cell tumor, because that's why if you encounter germ cell tumor in your practice, you need to exclude a mixed type of germ cell tumor. So for let's say you found a yolk sac tumor, so you need to exclude all of other type of germ cell tumor also, because there might be some differentiation of the other type of germ cells inside that main type of germ cells tumor. Right. So next is the germ cell tumor unrelated to germ cell neoplasia in situ. So these are almost the same, but these are more of sometimes they occur by itself and that's not related with in situ component. So you cannot find in situ component inside this tumor. Next is the Sachs-Scott stromal tumor of the testis, which consists of Leydig's and Sertoli granulosa, and also fibromaticoma, which is but this type of tumor is a bit rare, but still can occur. Um, the features is almost the same if you studies regarding ovarian tumor. So the features is also almost the same. It just it happens in the testes because there's a lot of germ cells or pluripotent stem cells inside the testes that can differentiate into any kind of cells. So the pathology is somewhat almost the same between ovary and also testes. And the next classification is the ovarian type tumor of the collecting duct and also retitestis. This the counterpart in the ovary is the all the cyst adenoma and sort of things. So you can see the serous cyst adenoma, serous tumor borderline malignancy, serous cyst adenocarcinoma, mucinous cyst adenoma, mucinous borderline, mucinous cyst adenocarcinoma. And so you can see endometrioid tumor, adenocarcinoma, and also clear cell adenocarcinoma, and also Brenner's tumor. So it's almost the same if you study regarding the ovarian tumor. So this is the counterpart inside the testis, in the testis. Tumor of the collecting duct and retitestis, you can see adenoma and so adenocarcinoma, and paratesticular mesothelial tumor, which is adenomatoid tumor, well differentiated papillary mesothelial tumor, mesothelioma. So of course, because testis is also encased by mesothelials, which arises from the peritoneal cavity. So it extends through the spermatic cords and into the and surrounding the testis. So you can find sometimes there's mesothelioma occur in the testis, whereas the tumors of the epididymis can consist of cyst adenoma of the epididymis, papillary cyst adenoma of the epididymis, adenocarcinoma, and also squamous cell carcinoma, and also melanocytic or neuroectodermal tumor, and the last one is the metastatic tumor. Right. So in penile pathology, you can see there's a benign tumor which is consists of condyloma acuminatus. So it still considered as benign, even though it is a part of a perineoplastic conditions. And next one is inflammation. This commonly found is a foreign body granuloma. So we also receive a few cases of foreign body granuloma where the people inject some foreign body or materials inside the penis, inside underneath the skin to stimulate the growth of the penis. So there will be some foreign body granuloma. For the malignant counterpart, I will only touch a little bit on the squamous cell carcinoma, which consists of 95% of cases, and other skin cancer, which consists of basal cell carcinoma and also melanoma. And a part of it, one more tumor is the extramammary Paget's disease. Okay, for the condyloma acuminata is usually associated with sexually transmitted diseases. So it is caused by HPV, similar as ladies. It's caused by the high risk type of HPV, which is HPV type 6 and HPV type 11, which is less frequently affected. But this depends on places, from places to places. So they usually occur in any moist mucocutaneous surface, usually at the external genitalia, any region, also the upper mouth. Right? So usually you can find in the multiple papillary lesion. Usually the size is 1 millimeter or larger. So here is the lesion. Here is when it grouped together, so it becomes a little bit bigger like this. So this part here is the gland penis. This is the shaft of penis. Alright. So this is the gland penis, the head of penis. Then this shaft of penis. So the stem of the penis. So usually the grossly 1 millimeter larger. So if you take a biopsy from that, you can see there's a arborescence or branching papillae with prominent central fibrovascular core. So it's just same like a verruca vulgaris kind of features. So this is how what HPV infection and HPV pathology will occur in the skin and also all the lining. So they will turn the lining into the verruca vulgaris kind of features. But there is no invasions at the base. So this is what clearly what differentiates between the benign and also malignant. So there is no invasion. So invasion is the most crucial words to say that this lesion is benign or malignant. So just in case in your practices, in your exam, you got the slides and you evaluate the tumor that given to you. So the first thing before you saying that this is a malignant, so you need to see the invasions. So invasion is mean the tumor encroach into the stroma. So there is a breakage in the basement membrane. So when the basement membrane breaks, the tumor will encroach into the stromal layer. And how to describe this lesion? You should say that the presence of papillary projections, this part here. To say that this is papillary, you should see something like villus in the small intestine. So it's coming out like this. So this is papillary structure. And number two, you should say, as I mentioned, there's no invasions. So you have a look at all the basement membrane here. You need to evaluate the basement membrane here, even though there's no special stain that I use. And they usually give a slide of H&E only. So just take a look around all of this basement membrane to see if there is any tumor encroaching towards the stroma at the center here. So sometimes, for example, if there is invasions at this part over here. So let's say the basement membrane continue up until here. There's a breakage here, and then the basement membrane continue back over here. So usually the tumor seeps from inside the main tumor bulk into the stroma. Even you can see sometimes there's a single tumor cells encroaching into the stroma. So it go from here to here, right? Next is the presence of colocytes. Colocyte is very common. Not common. It's actually a cytopathic effect. So it's a cytopathic effect of the HPV. So HPV will cause the cytopathic effect. Cytopathic effect, which is a colocyte. What is colocyte? Actually, it's a hyperchromatic nuclei and perinuclear halo. So here are the examples of colocytes. You can see there's a lot of it. So how does colocyte looks like? It's like that, but to help you understand, if you take a bigger magnification on each cells, the cells will be like this. So these are the cell membranes. The nucleus is somewhat hyperchromatic and crumply looks. So it's a bit, sometimes they call it resinoid or crumple kind of a nucleus. It's not nicely round shape or kidney shape like that, but it's more of a crumple like this one. So this not round or kidney shape like this one, right? And the nucleus, instead of it's homogeneously pinkish in color, it has a perinuclear halo. So the pinkish is still there, but there is a part of it which appear to have a perinuclear halo. So these empty spaces or clear spaces is what we call perinuclear halo. Alright, sorry for the poor handwriting using just mouse. Okay, and you should also see parakeratosis. This is parakeratosis. Parakeratosis means there's a layer of keratinization in which it has no nucleus seen in this layer. So at the skin, if you're comparing to the skin, is the uppermost part of the skin, or the externalmost part of the epidermis, in which it's just a very thin layer of a pinkish layer. So this pinkish layer does not have any. This is a keratinized skin. Keratinized layer of the skin. But usually in the normal skin, there's very thin. But in this case, the keratinization is increased, so we call it parakeratosis. And this order of maturation is not disrupted. So means that the maturation from the deeper or the basal layer of the epidermis up to the superficial part is not disrupted. Means usually the nucleus in the basal is more of a round shape, but as it go mature and towards the superficial or toward the external part of the skin, it become oval and also flattened. Next, the foreign body reactions. This is another example we can see. Usually can be seen in penile enhancement, in which they inject silicone, oil, or sometimes unknown substances of God knows who, God knows what, just to enlarge the penis for some apparent reason. So the consequences can be fat necrosis or foreign body reactions. And grossly, there will be deformity of the penis. So you can see the penis is deformity. The glands is just small things at the tip over here, and the rest of the penile shaft is somewhat become larger and also deformed. So, alright, so histologically, you can see multiple vacuoles, which represented by the stars. Even the small one is the vacuoles, and is surrounded by lymphocytes and presence of multinucleated giant cells. So some multinucleated giant cells is seen, or histiocytes is seen surrounding these vacuoles. So this is because these vacuoles usually contain the material that has been injected into the penis. For example, they inject oil. So this thing here inside here is usually contain oils, but due to processing, the oil become dissolved by alcohol during alcohol immersion or process during tissue processing. So you will be left with empty spaces, vacuoles like this one. And the next is the carcinoma or malignancy of the penis. It is caused by squamous cell. It is caused by squamous cell carcinoma. This is uncommon cancer in male, usually less than 1%. Circumcision is a mode of protections, rare because we rarely found these cases of squamous cell carcinoma in Muslims, Jews, and people who practice circumcision, and also in person who take better genital hygiene, who wash properly their penises. And the risk factor is also almost the same: HPV infection, which caused by HPV type 16 and 18. Sorry, this one is the high risk type of HPV, and the previously the condyloma acuminata is not the high risk. So this is the high risk. So it's similar with the cervical cancer, and it's also related with cigarette smoking. It occurs around 40 years old and to 70 years old. Why is this age is common? It's because it occurs because this age is almost 10 or 20 years after someone or a man becomes sexually active. So most probably they become sexually active or reproductive in their 20s, and after 20 or 10 or 20 years of exposure to HPV type 16 and 18, so around they are in their 40s, they start develop squamous cell carcinoma. This is also similar with the um, with the cervical sac cancer in females. So if there has earlier sexual activity, so after 20 or 15 to 20 years, they will, after they start to become sexually active and have, of course, if they have a multiple sexual partner and involved in high risk activities, after 15 to 20 years, they will start develop cervical cancer. So it's almost the same with the penile squamous cell carcinoma. Right, how does it look? So this is the removal of the penis. So this is the shaft of the penis, start here, from here until here. This is the glans penis, which is covered with prepuce. No circumcision done here. So you can see there's a growth that coming out at the tip of the penis, and there's also some growth over here and also over here, which already seem to be ulcerated. So usually, how to describe grossly, we say that this is a fungating mass or flat lesions, and it's the inner surface of the prepuce near the coronal surface. So it's actually more in the inward inside of the penis, in between the prepuce and the glans penis. It is a fungating kind of lesion. It's a cauliflower-like lesion, like in this picture. Sometimes it also occur in a flat lesion, which can be shown as epidermal thickening. In this picture, is here. This part here is the flat lesions. So this part here is the fungating lesion. So flat means it does not if you run through the surface here, you can see the smoothness of the overlying skin over here, but in this part over here is a bit rougher, like a cauliflower. So histologically, in any type of squamous cell carcinoma, in the skin, in the lung, in the lung, and also in the cervix, is almost the same. It is almost the same for the base part of the squamous cell carcinoma. So you can see dysplastic or atypical squamous cell carcinoma, and there should be a evidence of keratinization, which can be seen as individual keratinization or presence of keratin pearls. Individual keratinization, you can see the cytoplasm is a bit pinkish, and you can see the intercellular bridges, also the differentiation into the squamous cell carcinoma, squamous cells differentiation. And there's some variant, which is the varicose and so basaloid. This depends on the histopathology features. Again, this is the keratin pearls, almost the same as the lung tumor as that I mentioned previously. The intercellular bridge is not clear in this picture, but I think you already understand regarding the intercellular bridges from my lung lecture. So actually, intercellular bridges with interconnection between these bridges or projections in between these cells and the adjacent cells membrane. So there are projection connecting them. So this is what we call intercellular bridges. As the name implies, inter means in between, cellular cells bridges. So here again, you see this nicely. So these are intercellular bridges. Just a fine projection extending from one cell membrane to another cell's membrane. So you can see it's connected like that. Again, this is why they call pearls, because when they cut into the pearls, it's not the external surface of the pearls, but it's actually the cut section of the pearls. So when you cut the pearls, you can see there's a lamellated kind of a layering like this. Next is basal cell carcinoma. Histologically, it consists of nest and cluster of tumor cells, and show nuclear palisading at the periphery part over here, with a peritumor clefting. So there's a peritumor clefting. Clefting means it's the tumor island of tumor is separated from the the stroma, so you can see the clefting there, and it's composed of baseloid cells. So that's why, and the low power you can see is bluish, some sort of lymphoid cells, because it's bluish in color. So that's why the term baseloid come in. Hence, baseloid means basals. Basals, you know what? Why is it called baseloid? Baseloid. So it arises from the term base. What is base? It's a alkaline. So in coloring of histopathological slides or histopathology slides, they heavily use the base or the alkali and also the acids. So when there's a use of base and alkali, or base and also acids, this will give different color. So if it is acidic kind of a cells or kind of structure, it will picks up a more eosinophilic or pinkish kind of color. If the structure is basal or base or alkali like kind of cells or structure, it will pick up more of a bluish or maroon, deep maroon kind of a color, for example in the nucleus. So that is why it's called base. The term baseloid come from. So because this is more like nucleus kind of coloring, so it become bluish in color. So apart from that, you can see a lot of mitosis and also apoptosis inside these tumor cells. So this part here is melanoma, similar as the skin tumor. I won't go into detail. So it's a malignant tumor. You can see cluster nest of malignant tumor invade the dermal layer with desmoplastic stroma and show melanin pigment inside the cytoplasm, and the tumor have cherry red nuclei. So you need to describe all these things before you conclude that is a malignant tumor. So melanoma. So here, the center here is the nucleus, and you can see there's a nuclear layers at the center, inside the nucleus here, which is something described as cherry red kind of color. So this is grossly how it looks like. It looks like a spot of black, like a nevus, but it's irregular size, shape, and also the surface of it. Next, the extra-mammary Paget disease, which can occur at the scrotum, and it usually arises from the apocrine tumor. So when there's a tumor arises from the apocrine structure of the skin, it can invade into the epidermis and cause extra-mammary Paget disease, as you can see in this part in this picture over here. So there's a redness, there's crusted of the skin at the groin area, and you take a biopsy, you can see the tumor is only consists or comprises at the epidermal layer of the skin. So this epidermal layer of the skin, you see there's a keratinized part or layer of the skin, the granular layer of the skin, and you can see inside the epidermis there's islands of these cells. So these are actually the malignant cells that invade the epidermis. So this is the term called extra-mammary Paget disease of the scrotum looks like. So all of this is a malignant cell that invades into the epidermis. Next, we go to the testis and the pathology. I'll only touch on the germ cell tumor, a little bit on germ cell tumor, and also Sachs-Scott stromal tumor. Okay, germ cell tumor can be divided into two. This is not according to WHO, but usually we divide it into these two categories for easier understanding. So it can be divided into seminimatous and so non-seminimatous germ cell tumor. Seminimatous, which almost the same with the germinoma inside the ovary. So under it there is seminoma and also spermatocytic seminoma. And also for the non-seminimatous, there's embryonal carcinoma, yolk sac tumor, and so choriocarcinoma, and also teratoma. So this is a bit summary. Seminoma occur in 40 to 50 years. The age is around 40 to 50 years old. The tumor marker 10% only has HCG. Next is the embryonal carcinoma, which occur in patient around 20 to 30. Spermatocytic tumor 50 to 60. Yolk sac tumor is a bit younger, around 3 years old. And 90% of yolk sac have elevated AFP. Next is choriocarcinoma in 20 to 30 years old, with almost all patients, not almost all, 100% means all patients has elevated HCG. Teratoma occur in all ages, and also mixed tumor occur in 15 to 30, and based on what type of the tumor that happens, so different type of tumor marker can be seen in the blood. For the germ cell tumor, incidence is around 6 over 100,000 people. Age is 15 to 34 years old. Risk factor is testicular dysgenesis syndrome, cryptocortism, hypospadias, poor sperm quality, testicular feminizations. Genetically, you can see there's a polymorphism at the XQ27 locus. So there's just mutation that occur in a germ cell tumor. For the seminoma, Alright, most commonly, 50% of germ cell tumor, grossly it is a bulky mass, larger than normal testis, bulging. If you cut, there is a whitish cut surface with sometimes you can see invasion of tunica albuginea in less than 10% of cases. Histologically, there's a sheets of uniform tumor cells, poorly demarcated lobules. So these are lobules. The cells is usually large, round, with distinct cell membrane, clear cytoplasm, large central nuclei, and prominent nucleoli. So it looks like the tumor that resembles this is, of course, number one is I would say the germinoma of the ovary, renal cell, clear cell renal cell carcinoma is almost look the same, but there's some distinction in the sites of the occurrence. But if you can't remember, just remember is to have a clear cytoplasm with a round nuclei in the center. So apart from that, there's a prominent lymphocytic infiltrations in their shaft, or in their in their septae. And in spermatocytic seminoma is very uncommon tumor. It's only 1% of germ cell tumor. In old age, slow growing, but it's not metastasized. Usually it has an excellent prognosis. The histology is a bit different from the typical or classical seminoma. It has a medium-sized cell with eosinophilic cytoplasm and round nuclei, and the cell is a bit smaller compared to the classical seminoma, and there's also scattered giant cells. So this is how it looks like. So it's a bit different, right? So more like a lymphoma kind of features, with some presence of giant cells, scattered giant cells here and there inside the tumor. For the embryonal carcinoma, this is a very aggressive tumor. It's in 20 to 30-year-old men. Grossly is involved part of the testis, just part of the testis. So the rest of this yellowish tissue is just a normal testicular tissue, whereas the tumor is at the center here. Again, is a bisected testis. So it's slightly larger than normal testis. It has a variegated cut surface and usually extend to tunica albuginea. So histologically, it's a solid pseudoglandular alveolar, tubular papillary. So these are the pattern of the growth. So consists of primitive epithelial cells with high-grade features, including large nucleus, epithelioid, anaplastic, and also sometimes giant cells. So that's all those things here. So here is one mitosis, center here, and the rest, the dark one is apoptosis, is another mitosis. This is choriocarcinoma. Again, even though it is in testis, choriocarcinoma is one of the common tumor that can occur in the testis. This is a highly malignant tumor, small palpable nodule, less than 5 cm. Histologically, it consists of syncytial trophoblast cells, which is large hyperchromatic nuclei abundant in eosinophil cytoplasm, and also cytotrophoblast cells with regular medium-sized distinct cell-bordered clear cytoplasm arranged in mesh nest. So in this case, just to help you orientate, where is the syncytial trophoblast? Syncytial trophoblast, as the name implies, syncytial, so it appears to be syncytium. What is syncytium? Means the cells combine and group together. So it just look like one giant cell. So this is syncytial trophoblast. You can see few cells that groups together. You can see there's a lot of nuclei inside here. So this is the syncytial trophoblast. Whereas the cytotrophoblast means cyto means cells. So where are the cells? So these are the cytotrophoblasts. You can demarcate the cell singly like this. So when you can then demarcate cells with a bit clear cytoplasm. So these are all the cytotrophoblasts, right? And next is the teratoma. Teratoma again is just normal. Not normal. It's almost easily the same as the counterpart in the ovary. So it occur in the age, group of complex tumor, various component of normal derivative from more than one germ cell. Okay, you need to see two or more. You should see the cells that arise, the tissue arises from the endoderm, mesoderm, or ectoderm. So I won't go into detail. You can have a look, and it's almost the same with the ovary counterpart. Grossly is an open testis. You can see the content is complex material. You can see hair, fatty tissue, and also greyish tissue, sometimes teeth, bone, cartilages inside the tumor. Histologically, they mature from all of 3 germ cells layer. These are some example: cartilage, mature ducts, so any ducts or glands, hair follicles, respiratory epithelium, and some glands. I don't know what kind of glands here. Okay, so more is like more of intestinal or colonic kind of gland, right? So there's a presence of multiple. It depends case to case. So you see a mixture of this structure. So you know that all of these conclude as a mature teratoma. For the yolk sac tumor, it can occur at any age with a good prognosis, usually mixed with other germ cell tumor, especially embryonal carcinoma, and produce alpha-fetoprotein. Grossly, homogeneous yellow-white cross sections. Yolk sac tumor is another kind of a tumor that can occur at any age with a good prognosis, and usually it's mixed with other germ cells tumor, most commonly the embryonal carcinoma. And this tumor produces alpha-fetoprotein. And grossly, it look like this. There's a homogeneous yellowish white cross section. This look like a fatty tissue. And histologically, there's a reticular network of cuboidal or flattened cells. So it can be cuboidals. Cuboidal is like a square kind of cells, so cuboidals, or flattened. So it's a bit flatter than. It's not squamous-like, but it's a more flatter kind of cells. So it's either cuboidals or flattened kinds of cells that lines the network. And again, it shows papillary formations with the solid cords. Yeah. Papillary here does not mean the presence of papillary fronds like a villus in small intestines, but it's more of a histological structure. So how to recognize a papillary in histology, apart from having this digitalized fronds like this, is through the cross section of papillary. So what are the cross sections? So it mean that they got a center of fibrovascular core with a outer layer of epithelials. So when you see this kind of features, so you know this is a cross section of papillary. So why does these features is identified histologically? Is because the papillary structure is cut like that. So you cut through this. So when you look from here, so we have look at the cross section here, so it will be like this section over here. So you have a center fibrovascular, fibrous and also vascular kind of structure at the center, with epithelial lining at the outer part of the structure, right? So sometimes this structure, which we call it papillary, is termed Schiller-Duval bodies. So this is Schiller-Duval bodies, where it resembles endodermal sinus with a mesodermal core in here, with a central capillary. So you can see red blood cells within the capillaries, and it has a mesodermal core, and surrounding it is the tumor cells. So this structure you see in the histological slides. So this most probably is a yolk sac tumor. Alright, for the sex cord stroma tumor, there are two that I would like to stress here: is the Leydig and also Sertoli cells tumor. The Leydig cells arises from the Leydig cells. This Leydig cell is supporting cells of the testes, apart from the main tissue that produce spermatozoa. So the Leydig cells is supporting cells of the testes. It produces androgen and also estrogen, but more of majority of it produces androgens. That's why it present in the testes. So age is around 20 to 60 years old, and might present with gynecomastia because the presence of estrogen, the production of estrogen, that are also seen in this tumor. And 10% are malignant, and otherwise other from that is a benign. Grossly is a well circumscribed lesion and homogeneous golden brown cut surface. So when you cut open, you can see the color of the cut surface is a bit golden brown, golden brown kind of color, especially at the periphery here. You can see in the picture. So all of these are what we call the golden brown color. Histologically, it has a large round polygonal shape, so it's a bit polygonal like squamous cells, with a round central nucleus and lipid granules in the cytoplasm. So these are the lipid granules. Lipid granules in the cytoplasm. But here, these pictures showed you in this photomicrograph is the presence of lipofuscin pigment. So apart from the seminal vesicles, this type of tumor also has lipofuscin pigment, and sometimes Ranke crystals also. This is Ranke crystal, this is lipofuscin, sorry. This is Ranke crystal, and also this is lipofuscin pigment. So these two things can be present in the Leydig cell tumor. For the Sertoli cell tumor, it's a silent tumor. Usually it's incidental findings in a testicular mass. Mostly are benign. Grossly it look like grey, white to yellow cut surface, and histologically the tumor cells is arranged in trabeculae. So this is how trabeculae and cord-like structure. Trabeculae and cord-like structure. And the last part is the prostate gland pathology. Benign. it just has the most common pathology that occur is there are two types. Number one is benign pathology, which is benign prostatic hyperplasia or nodular hyperplasia, and the second one is malignant or adenocarcinoma of the prostate. So BPH, also known as nodular hyperplasia, incidence is increased by age. In 80 years old men, the incidence increased in about 90 to 90%, whereas in 40 years of age, the incidence rate is only at 20%. And this is caused by exposure to the testosterone. So this is how the pathogenesis of the BPH is going on. So it starts with testosterone stimulation. So it's actually in BPH it will stimulate both the proliferations of the stromal and also the epithelial cells. Similar as counterpart in the female, you can see this type of pathogenesis in fibroadenoma, in which both the stromal and also epithelial cell become hyperplastic. But in this case, in the prostate, so the testosterone will stimulate the production, the proliferation of stromal cell and also epithelial cell, both of them. Especially when it stimulates the stromal cell, it's the enzyme of the testosterone will being reduced into DHT, dihydrotestosterone, and then this dihydrotestosterone, apart from stimulating the stromal cell, it also stimulates the epithelial cells. So epithelial cells will also receive direct stimulation from the testosterone and also from the dihydrotestosterone that are produced by the stromal cells. So when they both are being stimulated, this will cause increase in growth factor, and then this growth factor release back in the circulation, and then it will auto stimulating both the stromal cells and also the epithelial cells to keep on growing. So this is how the pathogenesis of BPH is going on. Grossly, it's simple. The enlarged prostate, as the name implies, lobulated. It appears to be lobulated, and cut surface usually is a whitish cut surface. You can see at the center is the urethra opening. So these are how does the BPH look like. Histologically, because of this both pathogenetically it is caused by the proliferation of both stroma and also epithelial cells. So you can see there's an increase in proliferation of both glands and also stroma. Apart from that, the glands preserve their bilayer lining. So this is important because even though it is hyperplastic, it's not neoplastic, and it is not malignant. So it still preserve their normal architecture, which is the bilayer lining, which consists of basal cells and also luminal epithelial cells. And you cannot see any features of invasion, for example, necrosis, desmoplastic stroma, and mitosis. So there are not much increase in mitosis in this type of lesion. So again, this is a more close-up view. So the basal cells is flattened cells that are lining towards the stroma, whereas the luminal epithelium is pointing towards the lumens. And sometimes you can see the corpora malacia, which is the hardening or thickening of the secretion that are produced by these luminal epithelial cells. For the prostate adenocarcinoma, it consists of 29% of cancer. It occurs in men more in 50-year-old and above. Pathogenesis is caused by androgen exposure. This is similar, but in a sense that it is not due to androgen exposure causing it to transform into prostate adenocarcinoma, but the prostate adenocarcinoma occur by some stimulation due to genetic mutation or any kind of a stimulation, carcinogenic stimulations. But these cells, the prostate adenocarcinoma cells, is very sensitive to androgen. So androgen will stimulate the
increase in the increase in the size and also the amounts of cells of prostate adenocarcinoma cells. So that's why one of the treatment is to do orchidectomy to the patient to remove the testicles, because the source of androgen is mainly the testicle. So when you remove the testicle, hopefully then the prostate adenocarcinoma will become subsided, or become not less being stimulated, and this will cause it to assist in the treatment. For the serum tumor marker, so of course the PSA will increase, the prostate specific antigen will increase in the blood. Clinical cause, it may metastatic to spine and also lungs, but most commonly we can see that it mets to the spine. For the treatment, it can be surgery, radiotherapy, and also hormonal manipulations. For the surgery, of course, do a radical prostatectomy, because that's the main culprit. You can do the radiotherapy for the metastatic part, and hormonal manipulation by doing achidectomy or anti-androgen to the patients. So this is how does the prostatic adenocarcinoma occur. It can cause by hereditary, environment, and also acquired genetic aberration, whereas the androgen here plays a role to increase the production or the division or proliferation of the prostatic adenocarcinoma. So androgen stimulate prostatic adenocarcinoma, but it do not cause prostatic carcinoma. Okay, you need to understand this. Androgen do cause benign prostatic hyperplasia, but it does not cause prostatic carcinoma. Right. Asian is a very uncommon race, race to have prostatic adenocarcinoma, but it's more common in African American and also Scandinavian. And if your first degree relative has had been diagnosed or had been being affected or being contracted prostatic adenocarcinoma, so the first degree relative is at increased risk. So it means if the father had a prostatic adenocarcinoma, most probably the sons is at risk to develop prostatic carcinoma in the future. So sometimes the environment play a very important role, especially in the westernization of our diet nowadays, in changing in diet. So this is not clearly understood, but but from research and from previous studies, it does seem to have some association with the changes in diet. So meaning westernization of diet, mean if you eat more burgers and steaks, other type of western kind of food, so this might cause increase in risk to develop prostatic adenocarcinoma. This include migration. Of course, when you migrate, the only food that there is the one is local food. So there might be changes in diet also. So the migration is closely related with the changes in diet. And sometimes genetic aberration, this unfortunately that occur in a person or in the patients. TMPRSS2 gene ATS transcription factor is the gene rearrangement, and mostly found this gene arrangement is cause it is usually found in 40% to 60% of Caucasian prostate cancer. So this will increase the proliferation and sensitivity to androgen. So this fusion gene will cause the prostatic adenocarcinoma cells become sensitive to androgen and easily to make them easily to increase the proliferation. So that's how that's why when there's these genetic aberrations, this will cause the prostatic adenocarcinoma will keep on growth a little bit faster compared to the one who does not have this genetic aberration. And the other mutation is PI3K AKT pathway activation of transcription MYC protein this will cause cell cycle progression and progress into prostatic adenocarcinoma proliferation. Okay, for the for the pathology, grossly the prostate is enlarged. It is of course enlarged. There is a whitish ill-defined lesions in the prostatic parenchyma. So this is a prostate. This is the center here is this is how they cut it. Just to help you to orientate, they cut the prostate this way. So there is a cross section from here. You can see my laser pointer is here, right? So at the center here is the urethra. The slit-like opening here is the urethra. So the rest is the prostate tissue, but you can see there's an ill-defined tumor over here. This is the tumor. This is an ill-defined tumor over here, which occupying the prostatic stroma. The prostatic parenchyma. It pushes the urethra and causing urethra to become narrow. So that's why patient come with symptom of again here is the close-up picture. So that's why, because the urethra becomes slit like this. So that's why patient come with the symptom of urinary retention and also urgency, frequency, and all those things. Histologically, is when you say anything related to adenocarcinoma, the most important thing is to identify or to see it is a gland-forming tumor. So if there is no gland-forming tumor, you don't say it is adenocarcinoma until you do some other stains. But if there is no stains based on the histopathological H&E stain only, you should see there's a gland-forming tumor before you say or conclude it as a adenoma or adenocarcinoma. But in this case, adenocarcinoma, you can see there's a gland-forming tumor, and the gland pattern is smaller than normal. Usually it is smaller and become larger in the later stage. Sometimes it's crowded, and sometimes the architecture is appear to be sort of syncytial kind of a structure. So you can see that there's you can refer back to the Gleason scoring. So Gleason scoring score or give a grade to how severe how poor the transformation of the prostatic adenocarcinoma from well differentiated until the poorly differentiated, or you cannot see any glands formed inside the tumor. And the most important thing, apart from the gland-forming tumor, to say that this is a prostate adenocarcinoma is the absence of the basal layer cells. So this is just only one lining without any basal layer, compared to the BPH, which still preserve their basal layer lining. And sometimes you can see the pleomorphism is not that marked. It's just up to the mild to the moderate degree of pleomorphisms. And most important thing is to see the neural or nerve invasions, which of course this give the prognosis, is a part of prognosis of the tumor. Okay, so this is enough. This is enough. You can see the nerve bundles here, and the rest is the tumor cells. And the rest of it, this is the tumor cell. This is another nerve bundles. These are the nerve bundles, and the rest is the malignant adenocarcinoma cells. Even some here start to appear to be a solid kind of a tumor. Alright, this is another view, almost the same type of malignant adenocarcinoma cells and also glands. And here you see what we call a cribiform kind of pattern, whereas in the solid tumor you can see there's a slit-like within this tumor. So this type of pattern is what we call cribiform pattern. And prostatic adenocarcinoma usually mets to the bones. It's really love the bone, especially the vertebra. So this is how does metastatic prostatic adenocarcinoma to the bones looks like. So it will it will cause the bone to become not rigid, to become fragile, easily break, and patient usually presented with a pathological fracture. So when there's a pathological fracture, you could suspect metastatic. It's not from prostate alone. Any kind of metastatic to the bone will definitely come with pathological fracture before they find out. So here again, how does it looks like in a close up. Sorry, the resolution is not that good, right? So by that, I think that's the end of my lecture. I wish you all the best for the incoming exam. So this is some of this link is a old one, but you can search my name and you can find me on Twitter or X, Facebook Messenger, and also Instagram for any future reference. Thank you.